So, starting off with the case of a 70-year-old woman who was admitted to the hospital, who has a history of cirrhosis, presumably from non-alcoholic steatosis, has a prior history of esophageal varices seen on kind of screening EGD, but no history of esophageal bleeding. Had a prophylactic band about a year ago on Nadolol, some clinical evidence of ascites on Lasix, but never any clinical encephalopathy and no evidence of HCC on imaging. She initially presented with hematochezia for about 5 days with a 2.4 hemoglobin drop, flex sig notable for internal hemorrhoids and grade 2 rectal prolapse, thought to be the source of her hematochezia. But then 2 days later, she reported epigastric pain and unwitnessed black stools. So she said that she saw a few stools that were very dark, but no witnessed hematemesis. And on exam, though, reassuringly, her hemoglobin kind of remained stable throughout these episodes. She was stable, and she actually had brown stools on exam. So, no, the pretest probability of her having kind of a new esophageal bleed was quite low given her clinical stability, but given her risk factors and her history and her EGD that was done over a year ago, the plan was to repeat an EGD for her while she was admitted. And so I apologize, I didn't have a video for this, but basically this is what we saw going in. This is like in the fundus of the stomach, in the left here, and then on the right, and then the lower image is when the scope was retroflex. And so we saw these like plump kind of submucosal lesions that kind of actually were throughout the entire kind of fundus of the stomach. But interestingly enough, she didn't have any significant esophageal varices, most likely due to eradication from her prior exam last year. And obviously she does have these like snake-like mucosa consistent with portal hypertension gastropathy. But we ultimately thought that these like very pronounced diffuse submucosal like plump lesions were ultimately gastric varices. And so I wanted to talk a little bit about gastric varices. I do sometimes feel like they're like the stepchild of esophageal varices, especially when it comes to research. And so gastric varices are actually less common than esophageal varices, with an incidence of that very variable, anywhere from 2 to 20%. The risk of bleeding is actually lower. However, when patients do bleed from GVs, they have a higher morbidity and mortality rate. And as you all know, gastric varices develop when blood that normally would shunt to the liver through the portal vein is impeded because of portal hypertension, most often, resulting in diverted flow to alternate venous pathways and increased pressure in the gastric veins. So I think it's important to discuss the classification system for gastric varices because it can actually help risk stratify in terms of who is most likely to bleed. And it also can help with intervention. And so the most common classification that we use in clinical practice is the Sarin classification. And so this is based on location and relativeness of gastric varices to actually esophageal varices. And so the two subtypes are gastroesophageal varices and then just isolated gastric varices. So GOV1s, as you can see from this image, arise from the lesser curvature up into the esophagus. So it crosses the gastroesophageal junction. And GOV2s actually arise from the fundus going up into the esophagus. And GOVs are actually the most common types of gastric varices, GOV1s being the most common. About 70% of patients who have gastric varices will have this type, and 20% will have type 2. IGVs, obviously, as the name suggests, don't actually involve the esophagus, right? So the type 1 only arises from the fundus, and then type 2 mostly arises from the antrum body of the stomach. And these are actually important to know because IGVs they're actually the most deleterious. They are the least common, however, can have more of a bleeding risk and high risk of death. And so, so location is a predictor of bleeding, along with obviously size of the varices, the Child-Pugh score, red whale sign. Location can kind of predict how a patient will bleed. And so I think GOV1s are the most common gastric varices to bleed. Then GOV2s are second. Oh, sorry, I apologize. It's type IGV1s are the most common in terms of bleeding rate, then GOV2, then GOV1, kind of like backwards. And so here is just a schematic of the venous system. And this is only important when we talk about kind of some of the therapeutics, which I'll discuss a little bit later on. But the large vein, the left gastric vein kind of feeds into the GOVs up here. The short gastric vein feeds into the type 2 of IGV, and then the posterior gastric vein feeds into IGV1. Obviously, there are a lot of collaterals, and so, but these are kind of like the main venous system here. And so I was actually interested in knowing, so what do we do about gastric varices? And so for this patient, when we saw this, obviously we didn't find a clear source of bleeding for her. We were never really convinced that she was truly bleeding from her upper GI source. And so for primary prophylaxis with patients who aren't bleeding, there's actually no evidence right now or no clear data to help us determine what we do. Certainly in clinical practice, when we see patients with gastric varices, we oftentimes do nothing. And so there's no well-established guidelines. Currently, non-selective beta blockers are actually first line, but that's mostly largely due to the prevention of other complications of cirrhosis. There's actually studies that show that we as clinicians should avoid doing band ligation with gastric varices. So, when we see esophageal varices, we often will band prophylactically. But for gastric varices, there's some literature that suggests that we should avoid that at all costs, and that's due to just more complication risk. So post-banding can lead to more ulcerations, can cause bleeding after the band kind of sloughs off, and also can cause failure to completely ligate the deep aspect of the varix and its feeder vessels. Just in terms of like what data is out there, however, there's like one randomized controlled trial that did suggest that there's like a therapeutic, which I will talk about a little bit later, called glue injection with cyanoacrylate, that this may be beneficial for primary prophylaxis, although this is not clinically, we don't really do this clinically as much from what I could gather. So this was a small randomized controlled trial out of a small center in India that essentially compared the use of glue injections versus beta blockade versus placebo or no treatment. So about 90% of patients or 90 patients who had large GLV type 2 with eradicated esophageal varices or large isolated type 1s were randomized in these three groups. And ultimately, it found that the bleeding was much lower in the cyanoacrylate group compared to the beta blockade group. And also survival was much higher in the cyanoacrylate group compared to the no treatment group. So this was like one singular study. It might suggest that this could potentially be a kind of a good prophylaxis, but I think it's not common practice, and these injections actually can cause hypercoagulability and can cause thrombosis. And just so if anyone doesn't know, these injections they're like glue-like substances that kind of act like they have adhesive properties, and induces polymerization and solidifies when in contact with the blood, which promotes obliteration of the vessel and also promotes local thrombosis. And I'll show you just a quick video. I guess the most importantly, how do we manage acute bleeding from gastric varices. Again, very high mortality, morbidity. According to ACG and other practice guidelines, actually the first line, again, is this injection therapy, and it's called GVO, gastric variceal aberration. And there are a lot of, actually, there are 2 randomized controlled trials that show that this is more beneficial than ligation for the reasons that I mentioned before. I'm not sure if we do this in our center, but I read a few papers on EUS guided sinus-acrylate injection and coil injection, and essentially just allows for sonographic visualization of injecting like these materials directly into the varix and into their feeder vessels. And then the coil injection is like literally putting like a coil in that can cause kind of like the hemostasis essentially and clot formation. And then obviously you guys are familiar with TIPS and balloon occluded retrograde transvenous obliteration. And so these are mostly used for refractory causes, refractory cases. And so when pharmacologics and when endoscopic therapeutics don't work, these are like the kind of the last 2 options. And there's also data that show that they can be beneficial, but there's just not that much data out there. And so just like a brief video on the cyanacrylate solution. So essentially, it's like a very fine needle that you have a primer with some form of saline, and then you directly inject into the varices or into the varix, and it kind of enlarges, and eventually is thrombosed. And you can do this endoscopically, or as I mentioned, guided with EUS. And then lastly, just to talk about balloon occluded retrograde transvenous obliteration. I think this is actually mostly done with the IR folks. So there are actually some studies that show that this might be better than TIPS in terms of rebleeding rates. So I thought it was like kind of important to mention. And ultimately, it's just introducing a catheter with a balloon, the end here, through the femoral vein, kind of into the ICV, and then the large renal vein, and then into the gastric venous kind of outflow tracts, using the balloon to occlude, occlude the venous system. And lastly, this is an algorithm that was proposed by the World Journal of Hepatology. Just, I like my algorithms. This, again, I don't know if this is common practice, but again, as I mentioned, some literature suggests that for primary prophylaxis of gastric varices, patients should technically be on the beta blockers to reduce kind of complications from cirrhosis. But if you're actively bleeding, again, practice guidelines do suggest that glue injection is actually the first line. And if it's not controlled, then we go down and do the TIPS and the BRTO, as I mentioned. And if it is controlled, the question is, what do we do for secondary prophylaxis? And actually, there's essentially no data to suggest that any of these therapies actually work. Some say that glue injection might be helpful. Some say, TIPS might be the most beneficial, but there's a lot of area, area that's kind of unresearched at this point. So that's just like a brief overview of like the therapies for gastric varices. Does anyone have any questions?
Jamila, that was a great overview on gastric varices, and the Sarin classification, as you pointed out, kind of separates into junctional versus non-junctional varices with 2 subtypes in each. We do, to your question that you alluded to about the therapies here. So we do offer EUS guided glue and coiling, although I think most recently this came up where the liver folks wanted to do an injection and we didn't have it in stock because of probably supply chain issues related to COVID. But you can do direct needle endoscopic vision injection like you showed in your video, or you can do it under EUS guidance, which is nice because you can see these plump vessels with Doppler, and you can actually see the flow kind of obliterate. But the sort of most feared complication with cyanacrylate injection is the systemic embolization. So you can see like PEs, you can see splenic vein and portal vein thromboses. Sometimes splenic infarcts have been reported. So there is some, some potential risk. And then You also, in some cases, can do combination EUS-guided glue and coiling. So some people have done that. I think Ken Binmoeller out in California has a published series on this, and it seems to be fairly effective. But yeah, it's a good overview of gastric varices. Any questions or comments from our participants? Chris?
So Jamil, that was awesome. Always a difficult topic and scary when it comes up. Just to add to Nikhil's comments. So before EUS guided injection came around, this was very commonplace to do, just like you showed with the needle. The thing is, and I think everyone needs to be aware, is that when you're doing this, your choice, there's different types of glues. Some glues have fast polymerization and clot very quickly, and the thought is that they may decrease the risk of embolism. Other glues are slow polymerization, and you can mix them with like Lipiodol, like a contrast agent, and do it under fluoroscopy to watch it. And the thing is that if you use a fast polymerization glue, you can damage the scope pretty bad, because the glue, if it gets on the scope channel, if it gets in the scope channel, if it gets on the lens, it can be very difficult to come off, remove, and it will often damage the scope and need to be repaired. So some people were using the slow polymerization glue so that it would avoid the scope damage, but the downside is that there's a higher risk of embolization. I agree with Nikhil. I think if this is going to be done, the EUS guided approach is far superior, because you can actually see where you're going. Sometimes people inject, they don't get deep enough into the varix. They're just injecting submucosally in the stomach wall. And they're, and the other thing that we should really work on getting, we've talked about this, is using an ultrasound endoscopic Doppler probe, because there's some very nice data showing that you can put the probe on the varix, prove that there's flow, inject, and then go back and use the Doppler to show that there's no flow. But as Nikhil said, the EUS kind of obviates that, because you're seeing the clot in the vessel form immediately and you're visualizing it directly. So.
And the other thing, thanks for including BRTO. That is definitely something that the IR folks do. It's pretty important when they do that to make sure that the vessels, particularly the renal vein, is patent. Otherwise, it's not going to work. So they do a lot of pre-work before to make sure that that's going to be effective. But it's become sort of the procedure of choice for isolated gastric varices.
I think it requires that you have a patent splenorenal shunt.
Splenorenal shunt, exactly.
If you don't have one, they can't do it. So to your point, I think they have to assess for that pre-procedure.
Right. Otherwise, it won't work. If you look at the plumbing of it, it won't work. So yeah.
Great case. Let's move on to our next presenter, Dr. Lauren Rabinowitz. Lauren.
Okay. Can everyone see my screen? Great. Okay. So I'm going to present actually a case that I scoped with Dr. Itzkowitz, and then we very quickly hand it off to Chris. This is a 64-year-old gentleman. He had a history of hypertension, hyperlipidemia, and diabetes, who actually presented with a couple of months of sort of mild weight loss and an intermittent sticking sensation during swallowing. The reason he had actually come into the hospital on the evening that Dr. Itzkowitz and I ended up scoping him was because he had a giant ham and cheese sandwich for lunch, and then felt it stuck in his throat and decided that he needed to seek urgent medical attention. A couple of things. So he had actually had quite a few endoscopic evaluations before coming into the hospital, which will become relevant in a minute. back in 2010, he had actually undergone an EGD and colonoscopy for some chronic diarrhea, didn't have any evidence of Barrett's noted, and an otherwise normal upper endoscopic evaluation. In 2014, he had developed some GERD symptoms, felt by his community gastroenterologist to be likely weight related. Again, underwent an EGD, and there was no pathology noted on that EGD as well. And then 4 years later, had a very similar episode to the reason he could come into the hospital when Dr. Itzkowitz and I ended up scoping him, and reported the sort of like sensation of a piece of steak feeling stuck in his throat. Didn't seek any medical attention for that episode, but the symptoms had resolved after 24 hours, and he had not undergone a subsequent EGD because he had had so many evaluations that had been normal in the past. When he came to us, he was just on a PPI, and actually his reflux symptoms had somewhat improved, but he did sort of describe this progressive dysphagia, particularly to solids, over the several months prior to coming into the hospital. So couldn't get my video to load, but I want to just go through what I'm calling EGD1, and then Chris's EGD2. But this was just as we were getting into the G junction, and you can see like maybe a little bit of prominence, but otherwise his Z-line, everything looked like relatively normal. We completed the rest of the evaluation, and it wasn't until we like really looked in retroflexion that there was this thing that seemed to be sort of dangling off of the G junction. Here's just another view of it. And by the time we had sort of turned around and really taken a good look, there was something kind of gnarly looking clearly up by the scope, which parenthetically was quite difficult to biopsy, because even in like full tight retroflexion, getting our scope close enough to be able to get good biopsy bites was pretty difficult. And then this is EGD2, which was done by Chris actually about a week and a half after the initial scope. And you can kind of see just the outline of the scope up at the top of the screen, but barely any evidence of this Goomba that Dr. Itzkowitz and I had seen flopping in and out of the G junction. But when Chris pulled back, this is actually what he was seeing flying around close to the very edge of the G junction distal esophagus. So this sort of flopsy mass that was protruding in and out of the G junction, making it difficult to see. Certainly, if we hadn't really taken a good look in retroflexion, easily could have been missed. And then sort of difficult to assess, is it actually at the bottom of the esophagus, or is it actually like attached to the bottom of the stomach? And then my favorite images from Chris's EUS with the positive green dot sign, where you can see that the patient was noted to, in addition to having this distal esophageal mass, also with two concerning appearing lymph nodes in the mediastinum and close to that mass area. So just wanted to do like a little quick review of esophageal cancer quickly. It's incredibly common, actually. It's the 8th most common cancer in the United States. There are 450,000 cases that are diagnosed globally each year, and it's associated with very poor survival. Interestingly, one of the few cancers where the survival rate is particularly terrible, 21% at 5 years for US whites, 14% survival for US Blacks. Actually, interestingly, looked at a paper on the disparities between this, and it's probably due to, unfortunately, access to healthcare and delays in evaluation and diagnosis. There's an interesting paper that was published in 2017 that just looked at sort of the global burden of esophageal cancers. The two major types obviously being squamous cell and esophageal adenocarcinoma, and how the burden of disease is predicted to change over time. I thought this was a very interesting look. The study actually pooled data from 15 years of incidence reports in 12 countries' national cancer registries, looking at type of diagnosis by histology, squamous versus adeno, and then sex and age as well. And what you can see better in this image is the fact that while the rates of squamous cell are actually declining pretty rapidly across the globe, even in places across what's called the squamous cell belt, which encompasses a lot of the Middle East and Mediterranean, the numbers are actually going down. But if you look at the incidence of adenocarcinoma, and particularly this paper, which was trying to do mathematical modeling to predict how the trends would change until 2030, you can see that the incidence is actually skyrocketing for adeno pretty much across the board. And so, I think what this sort of highlights is just the fact that there's been this giant increase in esophageal adenocarcinoma really picking up in the late 1980s. That's largely been unexplained. It seems to be that the incidence is rising most rapidly in very resource-rich countries, and perhaps that's because of the obesity epidemic in some part. But even when this paper actually controlled for obesity, they still found that the rates were disproportionately rising, particularly in the UK, Netherlands, and the United States, and especially in males and especially in white males. And it's actually quite dramatic. They're predicting that by 2030, which is only 9 years away, out of 1 in 100 men in the United Kingdom will be diagnosed with esophageal cancer before they turn 75. And so this raises a lot of really interesting questions about whether we should be thinking about screening for this, particularly in high-risk patients, like the patient that Dr. Itzkowitz and I had scoped. And then also the value of early diagnosis, because there are so many new endoscopic therapies that are available if this is caught early. Obviously, I'll turn this over to Chris in terms of what could have been offered for this patient had he not had positive lymph nodes, offering ESD, et cetera. But unfortunately for this patient, by the time we got to him, he had already had lymph nodes spread. He actually ended up seeking a second evaluation at Sloan, undergoing an esophagectomy, and he died anyway about 3.5 months later. So.
Wow. Yeah, I remember this case. So I think one major point that you touched on is prevention. And, it's actually, when you look at the statistics, the major risk factor for esophageal cancer, esophageal adenocarcinoma, is Barrett's esophagus. And Barrett's esophagus is a relatively uncommon condition. And Barrett's esophagus alone carries with it a risk of malignancy or malignant transformation of less than 1% per year. It's when you have Barrett's esophagus with dysplasia that you get an exponential rise in your risk for developing cancer. So, they've done the studies, they've done the, cost-effective analyses, and it's just not cost-effective to screen everybody for, even everybody with GERD, for Barrett's esophagus. The high-risk population are, older white males with chronic acid reflux. So that's certainly not unreasonable to consider doing a one-time screening endoscopy, but it's not something that should be done along with your colonoscopies. Even women with GERD, the guidelines do not support, screening these patients. I would go as far as to say that for all of us that take care of Barrett's esophagus, myself, Satish, Nikhil, I would argue that just about every patient we've ever seen with Barrett's associated cancer was something that was found at the time of presentation. I think it's pretty uncommon when we follow a patient without Barrett's esophagus that they go on to develop cancer if it was non-dysplastic. And I would also argue that, and I would think this is for the group in general, how many of you have done multiple endoscopies on a patient for whatever reason, and they had no Barrett's, and then at some point they developed Barrett's? So I think it's a pretty a relatively uncommon complication. And when you break down the statistics, the chance of developing cancer from it is pretty rare. But once they tip over into dysplasia, the chance of developing cancer is quite high. I'll leave it to that and keep it open for other comments.
Lauren, on the prior endoscopies that this patient had, there was no mention of Barrett's or anything like that. Is that correct?
And he'd had, interestingly, like multiple EGDs before he got to us, which is kind of unusual, right? And most of them were actually, one of them was for GERD, but the first one was, you know, for diarrhea workup. So it was interesting that somebody had taken a very careful look multiple times before he got to us. And it also raises that problem of the fact that like esophageal cancer can grow quite rapidly. The other piece that I thought was interesting is this case, in addition to really making the case for careful endoscopic evaluation, also really makes the case for EUS, because we scoped him. He ended up getting an interval CT scan of his neck, chest, abdomen, pelvis, which didn't find any evidence of lymphadenopathy or concerning lymph nodes. And then Chris, when you had scoped him like 4 days after this CT scan, where you can see the impression here, certainly found evidence of problematic or concerning appearing lymphadenopathy as well. So it really makes the case for that, for a careful endoscopic evaluation and an EUS as well.
Did he, you said he underwent an esophagectomy. Did he undergo neoadjuvant treatment with chemo and radiation?
No,
I mean,
he ended up, yeah.
And just to touch on your question from earlier, like what treatment options are there? So, you know, again, if you look at data, patients who present, patients with esophageal cancer who present with dysphagia, there's like an 80% correlation that they're already going to have locally advanced disease. And upfront surgery is really reserved for patients that have that has tumor that's invaded muscularis propria, but has not broken through the wall and does not have any lymph nodes. Otherwise, if you take a patient who has, you know, local tumor invasion beyond the wall of the esophagus and or the presence of lymph nodes, if you take them to surgery up front, there is an extremely high risk of recurrence in those patients. So I'm a little surprised that they took him. Maybe, you know, maybe he just wanted it out, but statistically his long-term outcome wasn't going to be very good. Typically for someone with this, they would get chemotherapy with concomitant radiation therapy. They'd get restaged and then they would undergo esophagectomy. But we looked at our own data here, and for patients with for patients who had malignant strictures from esophageal cancer who underwent chemo, only 12% of them ever made it to surgery. And that just fits with the data you're presenting, that the long-term outcome survival is poor. So pretty tough disease to deal with.
Great. It's a great example of pseudoachalasia. You know, we read about pseudoachalasia. It's on the boards. You know, we tell the medical students, we don't see it very often. What was really striking was how small the primary tumor was. Lauren, if I remember, we didn't see it on the way in. And even on the way out, there was just like this little tiny raised area that we both sort of like, we said, well, what was that? You know, and then we even had to like retroflex and sort of convince ourselves about that little prominence that was coming down on retroflexion. So even we might have missed it. You know, it was really subtle, but we did happen to capture a couple of shots that showed it. So it's a real sobering example of how small a lesion can be and cause achalasia-like picture, you know, with dilated esophagus, etc.
Thanks, Lauren and Chris and Steve, for those for the case and great comments. Let's head over now to our advanced endoscopy fellow, Dr. Nick Herter. Nick.
Hi. Let's share my screen. All right. So here's the case for today. The patient's a 58-year-old female. She has a complex surgical history, a little unusual. It sounds like she had SMA syndrome as a child. And she had a duodenojejunectomy. She subsequently, more recently, had a cecal volvulus, so she had a right hemicolectomy. And as a consequence of the adhesions from these prior surgeries, she had recurrent small bowel obstructions requiring lysis of adhesions. And this admission presented with nausea, vomiting, abdominal pain, and distension. You can see on this x-ray on the left, she has a very dilated loop of colon on the left side. And with rectal contrast, the contrast goes up to the splenic flexure, and you can see to a lesser degree some contrast proximal to the splenic flexure, but there's significant delay of it passing there. So she was diagnosed with a sigmoid volvulus. She underwent a flexible sigmoidoscopy with decompression, and then she underwent a completion colectomy with an ileorectal anastomosis. Post-operatively, she just never did well after this anastomosis. She felt okay for a couple days, then she stopped having gas, she had nausea, vomiting, she required an NG tube with very high output, and she wasn't passing any stool. And this was actually for a period of a couple weeks. So she had repeat imaging. This is post-surgical now. She has dilated loops of bowel suggestive of a small bowel obstruction. And on the right, you can see a barium enema. All you're seeing there is the rectum opacified with an abrupt cutoff and no passage of contrast beyond the rectum, consistent with the complete obstruction. So we took her for a flexible sigmoidoscopy, and this is the rectum. You actually don't see any lumen at all. There's a staple line with attempted passage of a wire. There's no lumen. The wire doesn't go anywhere through that staple line. There's this little nodule, which is a little suspicious, and actually the wire is able to sneak right past that. So what we're probably seeing there is actually granulation tissue from the surgery, and then a very, very strictured, basically completely obstructed lumen. So we're able to pass a wire through that and then perform serial balloon dilation, which we'll see here, in order to open this up for her. So we started very small. The smallest balloon is this 6 to 8 millimeter balloon, and we just go up incrementally here. And immediately you can see things start to open up. This is a very thin septum here at the anastomosis of just kind of scar tissue, granulation tissue, and it tears open pretty readily. We can be fairly aggressive with this because we know on both sides what we have. We have this big lumen here, and we have a very thin septum of tissue, and then we have the ileum on the other side. And so we actually serially dilate all the way from that tiny pinhole up to ultimately 15 millimeters in order to give her, you know, as much chance as possible of resolving this and having normal bowel function. So this is the end result. You can actually see the ileum through this opening. We actually pass a scope through it as well. And you can see bowel and stool, which is what we're going for. That's the final. So she did great after this. She had just immediate return of bowel function, and she was discharged several days later. She was seen in the office 6 weeks later, and she has ongoing bowel function, no symptoms of obstruction at all. She is planned for another endoscopy to evaluate the area and possibly repeat dilation if needed. So I just wanted to briefly talk about anastomotic strictures. We see these a lot, especially at this center because of the number of IBD surgeries that we have. This one's a little different because it wasn't IBD or malignancy, but it can happen after any anastomosis. The literature is a little interesting in how they define strictures. If you define it as any stricture that a scope can't pass, the incidence is much higher, but the incidence of truly symptomatic strictures that require therapy is much lower. So it's probably 10% or lower. These risk factors, I would be, if there's any colorectal surgeons, I'd be interested to see what you think about this. This is what I found in the literature, that potentially staple anastomoses have a higher stenosis rate than hand-sewn, but weirdly only in colorectal anastomoses, not ileocolonic anastomoses. Male sex having something to do with the pelvic anatomy, theoretically, and then other complications such as, if there's a dehiscence, pelvic sepsis, that makes sense. Some inflammation could drive stricturing, radiotherapy, and that more proximal anastomoses stricture more than distal anastomoses. And one of the initial therapies for this is often endoscopic dilation. It's very successful. It's in benign cases, there's a very high success rate. In the literature, looking at malignant cases, there's a lower success rate, I suspect due to occult recurrence. And many of those cases, they do report that after the dilation, they subsequently found a recurrence either on that biopsies from that procedure or from a later procedure. And so it's not necessarily a failure of the dilation per se, but just progression of disease. In benign stricture, sometimes they may only need one dilation. She may be one of these patients and she's doing so well, but on average, people need 2 to 3 dilations. And complication rates, these look high to me. Anecdotally, I don't think we see a 6% perforation rate from dilation, but this also, again, included cases that were malignant, and we don't dilate malignant strictures routinely because of this risk. And so if you know it's malignant, you probably would avoid this therapy. And I think that's why the complication rates look so high in these series. But all in all, it's a very successful treatment, especially in benign therapy. That is all.
Very nice.
So the incidence of strictures in stapled anastomoses is thought to be higher because the staples actually crush the tissue when they work, and there may be an ischemic factor in that. We see narrowing at the anastomosis very commonly, especially in the first 3 to 6 months. And after that, the scar tissue softens and the strictures dilate. And then most of the time, you don't even see the anastomosis clearly, even though it looked strictured early on. The solid stool itself acts as a dilator and helps keep these open. This patient, it may be a little bit more difficult because her stool is going to be liquid all the time because it's an ileorectal. And I think there is a tendency for it to stricture down again.
Thank you for that input.
I'd like to mention the case that we discussed 3 weeks ago, where the anastomosis is not at the closed sutured end of the rectum. The anastomosis is usually distal to that because of the way these anastomoses are made. And what you saw was where they made the puncture hole to make the anastomosis, but it's not at the line of stricture, at the line of the suture, the closed rectal segment. I think it's always worthwhile looking distal to that line because the anastomosis is rarely going to be just at the suture line.
Yeah, I think we see this a lot, and also especially with the ileocolic resections, the anastomosis is never forward. It's always kind of at an odd retroflexed angle. So you gotta kind of look very carefully for
the ileocolics are because it's basically a side-to-side anastomosis. But in this case, Jerry's absolutely right. With a transanal EEA stapler, a lot of surgeons don't like to bring the transanal stapler right through the staple line, and they frequently will bring it out a little bit distal to the transverse staple line and make the anastomosis there, so that you do end up exactly as this showed, where the anastomosis is not at the staple line.